Hello everyone, you are welcome to my YouTube channel. The title of today's discussion is Aetiology, Clinical Manifestations and Treatment of Diphtheria. What is diphtheria? Diphtheria is an acute, highly contagious, toxin-mediated infectious bacterial disease caused by Corynebacterium diphtheriae. Toxin production occurs only when Corynebacterium diphtheriae is infected with Corynebacteriophages carrying the tox gene. These are specific phages that infect Corynebacterium diphtheriae. There are 4 biotypes of Corynebacterium diphtheriae. These include gravis, biotype intermedius, mitis, and Belfati biotypes, which can cause disease. Quickly look at the characteristics of Corynebacterium diphtheriae. Corynebacterium diphtheriae is a non-capsulated, non-spore-forming, non-motile aerobe or facultative anaerobic gram-positive rod. The club-shaped appearance is due to the irregular swelling at one end, while the beaded appearance of the cells is due to the metachromatic or volutin granules near the poles. It lies in parallel at acute angles or as palisades to one another in stained smears, forming the VLW shapes, so-called Chinese character arrangement. As you can see in plate 1, here is the V-shaped arrangement, and the palisade arrangement, just like the palisade layer of a cross-section of the leaf. Excuse me, please. Epidemiology of Diphtheria. Toxigenic strains of Clostridium diphtheriae spread directly from person to person because of droplet nuclei. However, the tox gene may be spread by lysogenic conversion of non-toxigenic strains of Corynebacterium diphtheriae. Contaminated fomites, that is, inanimate objects, can spread the disease. What are the main drivers of epidemiology of diphtheria, or the risk factors of contracting diphtheria? 1, malnutrition, overcrowding, incomplete immunization schedules, poor sanitation and hygiene, urban migration, and close contact. All these can lead to outbreaks of diphtheria. Pathogenesis of diphtheria. Toxigenic strains of Corynebacterium diphtheriae are known to colonize the mucous membrane of the upper respiratory tract of children between the ages of less than 1 year to 5 years. Or they can colonize the mucous membrane, or rather the skin abrasions in skin abrasions in older persons from 60 years and above. These immunocompromised persons have waning immunity. And so from the mucous membranes of the upper respiratory tract or the skin abrasions, These toxigenic strains of Corynebacterium diphtheriae can initiate the production of exotoxin, which is made up of two components, fragments A and fragment B. Fragment B, excuse me, is responsible for transporting fragment A into the cell, and fragment A inhibits the polypeptide chain elongation by inactivating the elongation factor EF2. This EF2 is required for translocation of polypeptidal transfer RNA or tRNA from the acceptor site to the donor site on the host ribosome. This leads to abrupt cessation of protein synthesis and therefore leads to cell necrosis with the production of a pseudo membrane. Here is a picture of a patient with the pseudo membrane formation on the tonsils. The gene responsible for conferring the diphtheria toxin producing potential can convert avirulent or non-toxigenic strains to virulent or toxigenic strains through a process known as lysogeny. Diphtheria toxin is extraordinarily potent, as little as 100 to 150 nanogram per kg of body weight is lethal. Diphtheria toxin is composed of a single polypeptide chain of 535 amino acids. Here is a flowchart of the pathogenesis of diphtheria. First, there is the entry of the Corynebacterium diphtheria into the nasopharynx. Then, the initiation of the production of the exotoxin, which is by acquisition of the lysogenic Corynebacteriophage by Corynebacterium diphtheria. A potent exotoxin that inhibits protein synthesis is produced and causes extensive local necrosis and the formation of pseudo membrane, which can block the airways, and then toxin is absorbed from the site of the pseudo membrane and is distributed throughout the body. Complications of diphtheria include myocarditis, thrombocytopenia, nephritis, respiratory insufficiency, and otitis media. What are the clinical manifestations of diphtheria? There are two types of clinical manifestations of diphtheria. You have respiratory or nasopharyngeal diphtheria, very common in children, and cutaneous diphtheria, which is common in immunocompromised patients that are aged 60 years and above. The clinical features of diphtheria follows after an incubation period of 2 to 5 days. And the symptoms of nasopharyngeal or respiratory diphtheria vary from mild pharyngitis to hypoxia due to airway obstruction by the pseudo membrane. The pseudo membrane is a thick gray membrane which forms and extends from covering a small patch on the tonsils to covering most of the soft palate. Other symptoms include sore throat, malaise, anorexia, loss of appetite, hoarseness if the larynx is involved, and low-grade fever. The involvement of the cervical lymph nodes may cause what is called extensive anterior and submandibular cervical lymphadenopathy, the so-called bull neck appearance, which is shown in this picture. This is a child with bull neck appearance. In the case of cutaneous diphtheria, the skin lesions are usually covered by the gray brown pseudo membrane. The effect of the diphtheria toxin on the myocardium and peripheral motor neurons may result in life-threatening systemic complications. For example, dysphagia or difficulty in swallowing is a loss of motor function. Myocarditis and acute tubular necrosis leading to kidney damage are also life-threatening complications. Myocarditis may present as arrhythmia, that is irregular heart rhythm, and can occur early in the course of illness or weeks later. Myocarditis can lead to congestive heart failure and is often fatal. Let's quickly look at the laboratory diagnosis of diphtheria. Diagnosis of respiratory diphtheria is usually made based on the clinical presentation in order to initiate presumptive therapy quickly. Because if the pseudo membrane is formed, if care is not taken, it can obstruct the airway and lead to respiratory insufficiency and death. So, however, laboratory or definitive diagnosis of diphtheria can be done by using selective media for primary isolation. Mainly Tinsdale telluride agar, cysteine blood telluride agar, and Loeffler agar are some of the selective media used. Sterile cotton-tipped applicators are used to swab the pharyngeal tonsils. Calcium arginate swabs may be inserted through both anterior nares to collect the nasopharyngeal samples for culture. In well-prepared smear stained with methylene blue or alba stain, there are beaded rods in typical Palisade arrangement. Small granular and gray colonies with irregular edges and small zone of hemolysis can be seen on blood agar. It is important to take a swab of the affected area, especially the ulceration if it is cutaneous diphtheria or the respiratory diphtheria. If it is respiratory diphtheria, then pseudo membrane should be swabbed. The organism to be cultured must be on a selective medium containing the telluride, which allows for distinguishing Corynebacterium diphtheriae and Corynebacterium ulcerans from other Corynebacterium species that normally inhabit the nasopharynx and skin. However, biochemical tests should be performed to fully identify the isolate. The most important thing is following the isolation of Corynebacterium diphtheriae, it must be tested for toxin production. So the confirmatory testing for diphtheria includes culture to identify the bacterial species and the ELIC test to confirm diphtheria toxin production. This is the ELIC gel immunodiffusion technique. It's an in vitro immunodiffusion technique where the central area, you have the filter paper strip with Corynebacterium diphtheriae antitoxin, and then which is placed on the medium, culture medium, and then the non-toxigenic Corynebacterium diphtheriae, which is the positive control, is streaked across. Then the unknown which is often the patient's isolate, should be strict in the center. And then the third one is the non-toxigenic Corynebacterium diphtheria, which is supposed to be the negative control. Following incubation at equivalence zone, precipitin line, which is at 45 degrees angle to the streak, will appear. And this is evidence that the toxin from the toxigenic Corynebacterium diphtheria and the antitoxin from the filter paper strip will form the precipitin line. Laboratory diagnosis of other methods for definitive or laboratory diagnosis of diphtheria includes lateral flow immunoassay, PCR for diphthe gene, rapid CB plus and API Coryn strip are commercial kits which are used for the rapid identification of Corynebacterium diphtheria. What is the medical management of diphtheria? Diphtheria antitoxin has been used for treatment of respiratory diphtheria. However, it should be known that diphtheria antitoxin neutralizes only the circulating toxin and prevents progression of the disease, but does not neutralize toxin that's already fixed to tissues. A primary series of 3 properly spaced doses of diphtheria toxoid containing vaccines, for example, diphthe vaccine, which is a combination of diphtheria and tetanus toxoid and attenuated pertussis components. And then a booster dose at age 15 to 18 months is also given, or 3 properly spaced doses in adults. Antibiotics can also be administered. This includes erythromycin, aqueous crystalline penicillin G, or procaine penicillin for 14 days. It is important to confirm the elimination of the organism by carrying out 2 successive cultures of the specimen of the nose and throat or skin obtained 24 hours apart after completion of the therapy. If they come out as negative results, then this indicates elimination of the organism. However, a history of a severe allergic reaction, anaphylaxis to a vaccine component, or following a prior dose is a contraindication to further doses. Moderate or severe acute illness in a patient is considered a precaution to vaccination, although persons with minor illness may be vaccinated. Here are links for further reading. Thank you for listening.